Hello guys and welcome back to my channel. My name is Tommy, I'm a human nutrition student and researcher at the university. This is the Physiopathology series of videos. And today we're going to continue by talking about respiratory diseases. So let's begin. First of all, respiratory insufficiency. General concepts. Respiratory insufficiency is when we have an oxygen pressure below 60 millimeters of mercurium. The venous blood has 40 millimeters of mercurium in oxygen pressure, whereas the arterial blood, which contains the oxygen to give it to the whole tissues of the body, has a pressure of oxygen of 90 millimeters of mercurium. Hemoglobin is saturated with oxygen. Hemoglobin is the molecule that transports the oxygen. And there is a problem when the curve of hemoglobin is moved to the left, because this means that the hemoglobin doesn't release the oxygen to the tissue. You have to know that the curve we are talking about here is sigmoidal, which means that goes like this. And when this curve is moved to the left, then that means that hemoglobin will not release the oxygen to the tissues. Anyway, we have the tidal volume, the inspiratory reserve volume, the expiratory reserve volume, the vital and total inspiratory capacity. So the amount we breathe in and breathe out, the amount we reserve in inspiration, the amount we reserve in expiration, and the total capacity of our lungs. Types of respiratory insufficiency. So when there is a low pressure of oxygen, hypoxemia, lower than 60 millimeters of mercurium, dyspnea, tachypnea, tachycardia, cyanosis. On the other hand, when there is a high concentration of high pressure of CO2, we have hypoxemia, this one, and hypercapnia. This creates drowsiness, disorientation, tremor, or astaxis. The astaxis is the flapping. Alveolar hypoventilation is when there is a low oxygen and high CO2, and this is due because of a respiratory pump failure. Diffusion disturbance is when there is low oxygen and low CO2, and this has to do with alveolar capillary membrane disruption. And an impaired ventilation of perfusion is when there is a low oxygen and a variable CO2. So this AV-AQ ratio is basically the alveoli discharged versus the alveoli irrigated. This has to be in a ratio between 0.8, which is optimal, and 1. If it is above or below those numbers, we have a problem. There is this thing called the pneumocytosis type 1, which will create an interaction, and the pneumocytosis type 2, which has to do with surfactant. Hypoxia is the oxygen decrease. We have several types. The isotoxis is poor utilization of the oxygen. The circulatory is low blood flow. Hypoxemic is lower dissolved oxygen. And the anemic is the competition in the hemoglobin. For example, with carbon monoxide, which will create the sweet death because it has a higher affinity to the hemoglobin compared to the oxygen. So it competes with the oxygen occupying its place and therefore not providing oxygen to the tissues, and sweet death, as they call it. Hypoxia-induced factors will create apoptosis, which is the programmed cellular death. Response to hypoxia, we have the polyglobulia, and this will create thrombosis and hyperviscosity. Different tolerances depending on the tissue, of course. It's not the same the bone as the muscle or the fat. Hypoxia generated in sport is also used to improve the performance because there is an adaptation to low quantities of oxygen. The obstructive respiratory syndromes are a set of symptoms and signs affecting the airway. We have types here. The ones that affect the central airway, for example, edema of the glottis, the bronchial tree, the asthma, and the peripheral ways, the COPD. We're going to focus on these two. Asthma is reversible and can come and go. On the other hand, the COPD is irreversible, and it is created via chronic bronchitis plus an emphysema. Asthma has an early starting and bronchial hyperresponsiveness, and it also responds to steroids. On the other hand, COPD has a late starting, it is associated with smoking, and it is unresponsive to steroids. The asthma is genetic, and there is presence of the T lymphocytes, CD4+, mast cells and the eosinophils. The COPD is acquired, as we said, smoking. There is a presence of T lymphocytes CD8+, and macrophages and neutrophils. They both create airway inflammation. The asthma creates dyspnea, coughing and wheezing, as well as a whistling sound when breathing. It creates bronchoconstriction, edema, high mucus, and an inflamed bronchial wall. On the other hand, the COPD, the chronic obstructive pulmonary disease, has both emphysema and bronchitis, as we said. The emphysema is the air that does not interfere with breathing. This is because of a swollen alveolus or a ruptured alveolar wall. On the other hand, the bronchitis is caused with sputum and expectoration. The emphysema is pink puffer, severe dyspnea, low mucus sputum, low bronchial infections, and low respiratory failure. On the other hand, the bronchitis is blue blotter. They have a blue tongue. There is cog before the dyspnea. There are high amounts of purulent sputum, high amounts of bronchial infections, and a lot of respiratory failure because of high quantities of CO2. The emphysema is an irreversible destruction of the distal lung, having to do with the antitrypsin 1 deficiency. And this creates a barrel thorax, which is indeed useless internal air. These are people that indeed they have a big thorax, but not because they are jacked, but because they have inner air that they are not going to use for the actual respiration. On the other hand, the chronic bronchitis has high amounts of mucus gland hyperplasia, because of that we have a high mucus, cog, dyspnea, wheezing, which are pathological noises, and also the clubbed fingers. So now let's take a look at respiratory diseases. We have the pneumonia, which is the inflammation of the lung parenchyma due to an infectious agent. Classification by area of acquisition can be acquired, typical via the Streptococcus pneumoniae, or atypical, nosocomial or in hospital, or healthcare associated. Depending on the guest, can be immunocompetent or immunosuppressed, and according to the germ type, bacterial, viral, or fungal. The entrance via inhalation, oropharyngeal aspiration, hematogenous route, contiguity, the wound near the lung, whatever. The defense against that, it is cog, mucus, local defense factors, and also alveolar macrophages. And there are evolutionary stages, starting with the interstitial, then the confluent acina, then we have the hepatization. This is the phase in which the lung will look like a liver because of all the blood trapped in. And finally the resolution. Then we have pleural syndromes, pleural effusion, which is liquid in the pleural cavity via exudate or transudate. Exudate is serious causes, for example tumor or pneumonia, which indeed is red liquid, and transudate, for example, because of heart failure. Parapneumonic, neoplastic, tuberculosis, and hematic effusions. What we do here, drainage of the liquid and analysis to identify the microorganisms involved. On the other hand, we have the pneumothorax, which is air in the pleural cavity. So here liquid, here air. Spontaneous or induced. Spontaneous is the most frequent. The cause is unknown and it is separated in primary and secondary spontaneous cause. On the other hand, we have the induced ones, which are, for example, a chest trauma, iatrogenic injury. Then we have the pulmonary tuberculosis. Even though the tuberculosis sounds like a disease of centuries ago, it is not yet eradicated. Lung apex disease. There is a parenchyma destruction here. The lung cannot distend to its full potential, and it is produced by the Coccus bacillus, which likes oxygen quite a bit. The cure in the past was to go to the Mondays, because there is less oxygen, and therefore the cure could happen more quickly, because the bacillus will indeed die because of the lack of oxygen. And the treatment to the tuberculosis is from 7 to 9 months. That's it. This is it for this video. I hope you understood everything I said and you enjoyed these minutes with me. Thank you so much for watching. You can download this diagram in the description down below and study it very well. Remember to like, share and subscribe to my channel for more videos like this. I see you in the next one, in which we're going to talk about the heart and the circulation. Ciao!